My name is Art Lee. I'm from Florida, the atherectomy state. I appreciate the invitation here. I got this topic, and I wasn't exactly sure what it meant, the word segmentalized, so I feel like one of those cooks that need to make a steak with jelly beans or something and use that, so I did my best here, but let's see. All right, so here are my disclosures, and I tried to put all of them there, but we do a lot of atherectomy. We try not to use stents about 6 years ago, and then we sort of evolved into using quite a bit of drug-eluting stents, and then now DCBs, and then most recently now back to sort of what we were doing 7 years ago. All right, so femoral popliteal disease. So while the endovascular approach has really emerged as the first-line therapy, I think, for femoral popliteal disease, no single device modality has emerged as what I think as the gold standard. The disease segment obviously is a large territory and it covers a lot of different disease patterns. So again, segmentalizing it makes sense. So segmentalizing can be different things. So I put in here patient factors. So is it a claudican? Is it a CLI patient? Is it somebody who's going to be compliant with therapy and follow-up appointments? Anatomical factors. So what's the inflow? What's the outflow? Where's the lesion? Is it ostial? Is it into P2, P3? Lesion characteristics. So is it a chronic total occlusion? Is it just stenosis? Is it calcified? And then operator experience. If you've never deployed a Supera stent, maybe you're not going to want to use a Supera stent when you really need it. Availability of the devices. Again, you may not have lithoplasty and these kind of things at your institution. And site of service. So again, challenges of SFA intervention are obvious: long segment, high frequency CTO, lots of calcium. You can see that a lot of different forces, as you've seen, I'm sure, previously. Bending, kinking, compression. All sorts of motion. So Mehdi wrote this a few years ago in JACC, showing so many options for this area, but little consensus. It does show a possible strategy using a stent, stent-free approach or with a stent. And again, here's a relatively straightforward task D lesion. And if you ask the panel members and the audience, you can get 15 different answers of how to treat it, and nobody's wrong. So again, clinical situation, like I mentioned, anatomy and operator experience. And here's another example of an SFA occlusion, but you can see how calcified it is. So again, let's go through the data of everything I was tasked to do, but I warn you that you really can't compare data across trials. Very different patient populations, lesion characteristics, study designs, study definitions. Again, primary patency in some trials is primary patency by ultrasound with PSVR, and some of them include clinically driven TLR. So again, these have to be considered, and it's hard to compare trials, but it doesn't mean you ignore the trial data. So here's a graph putting some of the stents, the covered stents, DES, Supera on there, along with atherectomy. You can see 12-month primary patency. Here's adding to it. It's a busy slide, but DCB is on the top in blue. And again, very good 12-month patency rates overall for most everything. But again, you can't compare these trials. An example, I'll use over PTX again because I'm more familiar and I use it a lot. PTX was one of the earlier trials. We have 5-year data for a while now, and their PSVR threshold was 2.0 versus some of the more modern trials where we use 2.4 and 2.5. And again, 2.0 is a lower rate of stenosis, counting as stenosis. So here's just an example. If you take Lutonix balloon and you lower that PSVR from 2.5 to 2.0, it becomes a non-significant improvement at 12 months. Again, the patients enrolled in trials are different. So you can see calcification was much higher in the DES trial versus the DCB trials. Look at the protocols. So if you remember the enrollment criteria, you had to have a successful balloon angioplasty, pre-dilate, and as long as you don't have a flow-limiting dissection or residual stenosis, you can enroll them. But if you had that, they were excluded. Same thing in Medtronic's trial. Again, excluded if they had suboptimal angioplasty predilation. Whereas in Zilver PTX, remember, they didn't predilate. They went straight to stent initially in the primary randomization. And if they had angioplasty and they had suboptimal angioplasty, those were actually enrolled in the trial, okay, in the provisional PTX. And again, interestingly, those patients did better. So if you take those provisionals over PTX, which is what Cook shows most of the time, those patency rates were 91% at a year. So this just shows the pitfalls of looking at these trials and comparing them. So again, just going back 5-year primary patency, this is only for provisional. If you look at the whole cohort, it's actually lower at 66%. Good freedom from TLR. All right, so really quickly, nitinol stents were a game changer. But obviously issues with restenosis, fracture rates. We do have different versions of them now. So Supera, again, I think you guys have heard, it has the lowest chronic outward force, but very high resistance to deformation. So again, it can really hold the lumen, make a round appearance. I did one yesterday, and the IVUS images really do look like that. And I put a Zilver PTX up top because of the osteal disease, and it looked like the bottom one. So again, Supera had, wasn't a randomized controlled trial, it was more of a registry, but good patency rates. You can see 86.3%. This is very dependent on treating the vessel ahead of time before you put the stent in, because you want the stent to not have elongation or compression optimally deployed to get the best patency rates. All right, Viabon. I don't use a lot of these, honestly, but more so now below the knee with venous arterialization. But again, very long lengths, up to 25 centimeters, patency really dependent on appropriate sizing. So originally, you wanted to oversize it by less than 20%. The most recent studies, you really want to right size it to get the best patency rates. Failure mode is different than bare metal stents. It's really edge restenosis and thrombosis. And it does look like the restenosis is independent of length, as any therapy could be. And again, in Reline, I'll share the data in high Tosaka class restenosis. So again, it's gone through improvements, laser cut edges, heparin bonding, smaller profiles. But you can see these studies were very long lesions, like 19 centimeters on average. And you can see a very respectable patency rate of 70% here in that study, Viastar. Again, if you look, 78% all lesions, and over 20 centimeters, 73% versus 33%, which is very respectable. This was, which one was this? This is the Japanese IDE study. This is the most recent one. So again, you can see primary patency 88% at 1 year with 21.8 centimeter lesion lengths, 65% CTO. 2 years, it seems very durable. And then again, in Reline, which is for in-stent restenosis, you can see 17 centimeter lesions, 75% patency with 1 year versus some of the other therapies you see there. All right, drug-coated balloons. In a nutshell, 3 approved, and they've held up, especially, I think, Medtronic. And again, these are different trials, don't compare them, but Medtronic, you can see data out to 3 years, very impressive. We were using it more and more with the atherectomy to go away from the stent. But again, this came out in March and really halted a lot of the usage in a lot of places. So again, we're being a little more judicious with it. Okay, last thing. Eluvia, FDA approved, and again, really nice because this is a head-to-head trial. It has a polymer, a lower dose of paclitaxel. You can see the elution curves there. And head-to-head, patency was better with Eluvia than Zilver PTX. So an algorithm is, again, angioplasty, pre-dilating is very important, and depending on the result of the pre-dilation, you can go in the direction of whether you need a scaffold or not. I was going to show a case here, but I think I'm going to crunch for time. But okay, previous fem-fem bypass, bad claudicant, flush occlusion of the SFA. You can see the runoff actually is very good. Popliteal comes back with very large anterior tibial and probably a perineal. So again, a lot of options, even how to approach this. Surgery, antegrade, retrograde, CTO device, et cetera, et cetera. We ended up going retrograde because of the flush occlusion. Came back up to the ostium, couldn't get back into there, and so we re-entered with an outback. Eventually. All right. And exteriorized it. And then the question is, what therapy would you have done? DES, DCB, Supera, Viabon, and others. And really, is there a wrong answer here? I don't think so. Unfortunately, that's not playing. There it is. All right, in conclusion, challenging segment, no perfect device yet. You can't compare trials. I think there's a lot of factors to consider: patient-related, anatomical, lesion-related, operator experience. And again, pre-treatment really can help determine which direction you go and what device you use. Thank you.